connective tissue disorder also one of the important diagnostic or important differential diagnosis. Dr. Madhulika emphasized upon if you do ABG, lactate, ammonia, and urinary ketones, you will be able to make most of the diagnosis. So I'm sure that because of the hypoglycemia, maybe people are going out for lunch. But if there are any question, I'm sure there will be many questions. So 1 or 2 questions, I'm sure the lady will be very happy to answer. So is there any question from the audience? You know, the talk was so elaborate, I'm sure that nothing left for to discuss. So thank you very much, and we close the session now.
I would just take 2 minutes. I would want the honors done. We will have lunch after this, and then we will start in about 30 minutes. We are running slightly late. I'm sorry for that. I would request Dr. Ravindra Mehta. Is Dr. Ravindra Mehta here? He's come all the way from Sangrur in Punjab. I would request him to do the honors. First honor Dr. Faridi as the chairperson for this session. Dr. Faridi. Dr. Faridi sir, thank you so much. Thank you so much. And then I would like him to honor Dr. Sujata Sani. Thank you, ma'am. Thank you. And Dr. Madhulika Kavda. Thank you, ma'am. Thank you so much. We'll break for lunch and start in half an hour. 3 o'clock we'll start. And head of department at Maulana Azad Medical College with a keen personal interest in hem-onc and vaccinology to chair the session. And I would also invite Dr. Pyali Bhattacharya onto stage. Ma'am, please. And Dr. Manvinder Singh Sachdev, as I had mentioned earlier, Dr. Pyali will be talking on what troubles an adolescent, and Dr. Manvinder will be talking on an approach to child with congenital heart disease. I hand over to Dr. Dubey.
Thank you, Vinit, very much. Good afternoon, everybody. We begin a post-lunch session, and it is a potpourri, very well described, probably because we could not fit these 2 conditions. So we are starting with an adolescent problem, what troubles an adolescent, and then another problem present since birth, congenital heart disease. There has been a lot of talking about adolescent health, and as you are all aware now, IAP has said that till 18 years of age, it is the pediatric age group, and all these adolescents also should come under the care of pediatricians. A lot of problems with the adolescents. I hope Pyali will be able to cover most of them, because the issues are very much different, but let us see. She is working in the General Hospital of SGPGI in Lucknow, and as I could see, she is a trainer in many IAP programs, very well connected with various IAP activities. I will be listening to both the speakers for the first time, so it will be a good experience for me as well to listen to them. So the only request with both the speakers is that they should stick to the time. That would be wonderful. So Pyali, please. You can write your questions and then pass on. We will have the question answer session at the end. Thank you.
A very good afternoon to all assembled pediatricians here. I will like to introduce you to the world of the adolescent. The topic of today is what troubles a teen. So, the word adolescent was taken from the Latin word adolescere, which means to grow, to mature. So when we look at an adolescent, we should not think that it is an adult or half an adult. It should actually mean that the child adult. So at first, all pediatricians should try and understand
as pediatricians, as parents as well, how a teenager's brain is different from an adult's brain. You can see here that the direction of growth is towards the prefrontal cortex. So, an adolescent actually does not know about the consequences of his actions. However, he can relate to the emotional center where he understands that he will be rewarded. So, if we see the curve, we see that age-wise at the adolescent, he can ask, throw a tantrum or show some emotion, want some reward, but he has no planning, he has no future thinking. So at this point, the parent or the pediatrician should not actually be punishing him, but should be with him, understanding the disparity between the growth of the prefrontal cortex and that of the limbic systems. Now these are the three: early, middle and late adolescents. I have tried to elucidate here how the mind works, how the sexual maturity occurs as we proceed from 10 years onwards to 19 years. It is only in the 16 to 19 age group that the body is taking an adult form, has a distinct identity and has more settled ideas and opinions. So for a 10-year-old, the management is a little different from the 14-year-old and a little more different at the 16 years. Now, this is a typical adolescent who is coming to your OPD. His school has sent him with a form saying that his sports forms must be completed and the pediatrician must give him a certificate that there is no problem. His mother is in a hurry. She just wants to make sure that he is checked out once for any medical problem which might crop up and is on the way out almost simultaneously. So here comes our role as a pediatrician. What should we be doing? Should we only filling in their form and just letting them go? As we all know, the adolescent do not come much in contact with the pediatrician. So this is our chance where we can assess and try to manage if there is a problem with them or not. So while assessing the health problems of an adolescent, we have plenty of things to worry about. Number one is malnutrition, which all of us would be able to manage efficiently. Then comes depression, suicide, eating disorders, especially obesity at the present moment. There are addictive behaviors, accidents and violence, menstrual problems for the girls, early and unprotected sex, sexual abuse, and the latest is the cyber addiction and the cyber crimes. So what would be actually a clinical approach to such a patient? At first, we must engage the adolescent in conversation with us and assure him that we will be absolutely confidential with whatever information he is giving us. To engage the adolescent, maybe we can talk to him about his home, about his school, while giving him a thorough physical examination as well. Along with this, we go ahead with the HEADS assessment. For the pediatrician, he must remember that he is not a psychiatrist, he is not a psychologist, but he can actually effectively catch hold of. Now, once this HEADS assessment is done, we can identify areas where some intervention is needed. Maybe a motivational interview after that or some skill education. And then of course we should not forget the triage that we need to partner with the family and with the school. And then of course we can utilize some community resources like some NGOs or similar group which have been formed which can help these adolescent children with problems. So HEADS, as I said, is a very important tool for the pediatrician. HEADS means H, a home environment. We can start out with very small questions like where do you live, whom do you live with, are you comfortable in your home or do you have any problems? Education, employment and entertainment. Here of course we need to know entertainment has become very addictive. Several hours of television, several hours of cyber cafes, and of course education, we mean to ask them if they have been doing well in their grades, which class they are in and if they have been dropping out of school or not, what their, if they are working somewhere, many adolescent may be working in Domino's or some other place on a casual basis to earn some money for his own activities. Now, amongst these activities, what we need to find out is whether the child is exercising enough at schools, what are the games that he is playing, who are the people who are giving him company in these activities, if any of these friends are actually using drugs or smoking, what is the diet like, and then again you can carry onwards while doing his physical examination about the sexual activity. You can simply ask him some questions, whether he is comfortable, what kind of friends he has. At the present moment, of course, the third sex becomes important, whether his friends are girls or boys, or whether they are somebody else. You need to know how he is doing with these children. So, and of course, questions like, are you comfortable at home? Are you comfortable at school? And have you ever felt that your life is simply not good enough? Do you feel that you should want to do something other than this, or you want to stay in your home and not do anything, sit in a corner, just sit and weep? Things like this will guide us towards tendency for suicide and depression. And of course, the safety nets, especially more so for boys, whether they are using the seat belts in the cars, whether they are using helmets, and a very special safety measure for cyber safety, which we will talk about later on. So, going on to a few issues which I could cover over here are the mental health issues. The case one is a boy, Saurabh. He is 15-year-old. He is in his room. So his father tells him, tidy your room, this is a mess. So Saurabh is very oppositional. He says, I'll do it later, I'm busy. So what is he doing at the present moment? He is Facebooking. His father goes into a temper, screams at him, and Saurabh under his breath is muttering, Bhashan shuru ho gaya hai, arey yaar. So the father goes on and says, Badtameez ladke, sadak chhap ki tarah baat karta hai, this, that. Saurabh again mutters, uff, sala, a swear word. Father is shouting at him, he is shouting back at his father, they're dropping and banging things. So, and the father finally flings things around. Saurabh is flinging a chair around, and then he moves around the room angrily. His father shouting at him, Dekh lunga, sab band karwa dunga, school chhodwa dunga, things of that kind. So what is this actually? What we have here is actually a failure of communication. So this was a case of oppositional defiant disorder. What is this actually? You see, parenting for all of us is not a very easy art. So during parenting, we have these 4 forms of parenting: an authoritarian, an authoritative, an indifferent, and an indulgent one. While the authoritative is the best of the lot, let us see how they respond. So, an indifferent parent would say, adolescent would call up, say, Mom, are you home? So mom would say, okay, no, I'm going out for dinner again. So, what? Does not respond to the adolescent at all. She's just indifferent to her need. The authoritarian says, do it my way, or like Saurabh did, Saurabh's father did. So it's my rule, my house, whether you like it or not, you do it or you don't do it. Get out. Now the indulgent variant is again another one. The mother is telling the child, you want to party at home? Go right away. I'll give you the key to the liquor chest also. You can use your father's stock. Whereas authoritative would be disciplinary, but would negotiate, would compromise. So, if a child wants to go to the mall, the parent says no. You know, the family has plans to see your sick aunt, and that is necessary as well. We will drop you to your friend's house afterwards. So you negotiate and you talk to the child, discipline the child on that he cannot go to the mall, but you definitely don't shout at him saying that get out of my house. So it is, this, remember, is not a tug of war between the parent and the child. Next we come on to the body image. This is how the adolescent feels. Each time he feels mirror, mirror on the wall, who's the fairest of all? So the male, when he thinks of himself, the male adolescent thinks, I should have a macho figure, a muscular body. Everyone is Salman Khan these days. I must have a hairless macho body, athletic. So, and what does the female think? The female thinks, I'm Kareena Kapoor. I must have a zero figure. So, thinking this way, what happens is that they get into so many problems. Malnutrition, no exercise at times, over-exercise, muscle tears. So, not only that, psychologically it has been seen that about 50% of women, a shade more than the men, are dissatisfied with their overall appearance and their body image. So, this is a case where 17-year-old Hayan, this child came to us saying that I have a facial discoloration for the last 4 months. The parents brought the child over saying that he is too worried, doesn't eat anything. पहले chicken खाता था, अब तो वो भी नहीं खाता है. So irritable है, जवाब देने लग गया है. हर वक्त तो बाथरूम दौड़ता रहता है, पता नहीं क्यों क्या सोचता है. So when we did a heads, we found that there was a history of acne for the last 6 months. The child had switched about 8 doctors, applied a lot of creams including Fair and Lovely for men. And when we talked to him, he confessed that he was very, very worried about his looks, didn't want his classmates, especially the girls, to see him like this. So what was this actually? Was it a simple case of acne? During a heads assessment, it was assessed to be a case of body dysmorphic disorder. So what are the red flag signs? Why it was not a simple case of acne? Because here the concerns were difficult for others to see. For them it was simply a case of acne, whereas for the past 6 months the child was anxious, almost bordering on depression, worrying about this repeatedly, going to the washroom every time to check in the mirror if his color had changed a little from dark to white. Not only that, it had disrupted his daily activities, his social activities, and he was actually very bothered about the whole thing. So this was taken up as a case of body dysmorphic disorders, referred for psychological consultation, because such cases often have comorbid conditions like depression. So the psychiatrist put him on a cognitive behavioral therapy, and he was further briefed that expectation of the outcome should be normal, not too much. There's another case of 14-year-old Ricky. He was constantly refusing to go to school, aggression was there, and his mother was complaining that all the time he is with his friends. So this was a broken family on doing a heads. Mother was nagging constantly, father was a drunkard in a way. The child had a balanced diet, was very conscious of his appearance. He had lost interest in all his activities, but he felt that he wanted to die. He was feeling worthless and he had to be put on drugs, so he was having a poor drug compliance as well. So the points of concern here was that he was arguing all the time with his mother, showing disinterest in his homework with falling grades, and of course what actually made us prop up our ears was that the statement saying that he feels hopeless. So, are we dealing with depression? Ricky was made comfortable, confidentiality factor explained to him, and while as doing his general health, he was prodded and the heads assessment was done. He was called for another session when it was found that he was not doing well, but even after 2 sessions, Ricky did not improve. So he was referred to a psychologist, then to a psychiatrist, and later on this child was in depression and had to be put on fluoxetine. So what are the warning words here? I wish to die. I just want to go to sleep and never wake up. This pain will be over soon. Nothing matters. These are very depressive thoughts. And as soon as we hear these are warning words which should tell us that this child is depressed, may go on to do actions like suicide. So a quick treatment with the psychiatrists becomes very, very essential over there. Do not keep this child to yourself as a pediatrician. Another thing is, there is a trialogue between this adolescent, the parent and the professional over here. You need to talk to the mother as well, and if possible, this child was seeing his drunkard father as well. So you need to talk to the father and of course the school professionals who need to guide him in his studies a little more, motivate him and see that he does improves in his studies a little more. Next we proceed on to talk about sexuality. Now this is one sphere that we rarely talk to our adolescents. Sexual behavior, there are some behaviors which are acceptable, which are reasonable, but there are some others which are a cause of concern. So the expected behaviors are that the child will joke a little, will talk a little sexually, sometimes they will masturbate, there may be some hugging, kissing, fondlings amongst the schoolmates as well. However, if there is too much interest in pornography or promiscuity, or he is actually violating others' body space and being aggressive with obscene actions, these are causes of concern. So this is a case where Pranil and his screens, that is the laptop, is inseparable. The parents are complaining that he is always on the computer. The parents have now confiscated his computer and brought him to the pediatrician for help. Now on examining Pranil, he says, no, I go to the school regularly. I go for my tuitions every day. So how can I do excessive Facebooking? How can I do excessive playing games on the computer? My parents are untrue. That is the only way I can relax or stay in touch with my parents. So the parents on interrogation now come up with their main worry. They say he must be surfing porn because he locks his room from inside. So they are worried about the child surfing porn and they are nagging constantly. They are confiscating his computer now. Now this is a child where you need to address the issue of pornography. How do you do that? The child will not actually talk to you about pornography. So while examining him and doing his health assessment, we have S for sexuality as well, where we need to address him about how he uses his multimedia, which sites does he go to, what does he like, and then gradually you can ask him how he talks or feels about sexuality and gently actually prod him into talking about porn, what he likes, does he think it is a problem or whether it is a normal activity, how much has he been seeing, and has he any questions or has something in it disturbed him about pornography. During this conversation, you can actually explain to him that there are some problems with excess pornography, because these are not the true picture of the society. You need to bond, you need to form a relationship before you go into such actions. Not only that, at times it has been seen that many adolescents who use masturbation later on expect such things and thereafter cannot actually consummate after they are married. So you need to actually talk to the child and explain to him that this is not the real picture that you see. A word about the cyber safety. Cyber safety has come into vogue because we are now almost all the time on the net. The children should know that they need not respond to emails or messages which are inappropriate. And if you feel that it is not right, then please do come to us. The parent himself can actually give this message to his child. And not only that, the computer should be in a place where everybody is, it is visible to everyone. This is a real case scenario where this gentleman was actually grooming children, acting as a 10 or 18-year-old, getting their trust and then making them see pornography and actually exposing them to pornography. Now this is 14-year-old child. She did not want to go to school. Her grades declined. She was refusing. So when a health assessment was done, she quietly came out with saying that she goes to school alone with the driver. The driver makes her sit in the front seat and touches her inappropriately, and she is very afraid to go to her parents and afraid that she would get pregnant. So this disclosure has to be handled. Keep calm, give the child undivided attention, listen to the child, And there are a few do's and don'ts. The child should never think that you are not with him. So you have to be with him, and while doing a medical examination, please don't blame the child, please don't panic or overreact, aisa ho gaya, waisa ho gaya. And of course, do not call the person who is the offender to the child's presence and talk to him. Do not pressure the child to talk or make the child repeat the story. For our youngsters, they must understand, we must explain that there is safe touch and unsafe touch. Anything which is comfortable is a safe touch, whereas anything which is uncomfortable to them is an unsafe touch. So be a brick, be a role model, and help the adolescent.
Thank you, Dr. Pyali. You have beautifully covered some of the areas. What actually troubles these teenagers? We will take questions at a later age and introduce a term like dialogue, that we have to have a dialogue between teenager, parents and professionals, so 3 persons together. Good. Now I will request Dr. Sajdev. He will be speaking on approach to a child with congenital heart disease. Dr. Sajdev is working as a pediatric cardiologist at Sir Gangaram Hospital in New Delhi. Before this, he has his training at Chennai and worked for some period of time in Apollo Hospital and Hyderabad also. You can ask questions. Dr. Sajdev, you can start.
Yeah.
And I will again request that please limit the talk to 18 minutes or so that we can have sufficient time for discussion.
Sure. Now, my job here is to go ahead with an approach to a child with congenital heart disease. So why this is important is because most of us in our office practice, when we are busy, we are exceptionally wary of dealing with a child with congenital heart disease. The most common reaction is, there's a murmur, there is something odd, isko le jao, isko kuch ho jao. Now, that reaction has a negative impact on the mindset of the patient. So if we are able to systematically approach this child who has congenital heart disease in our office practice, we may be able to convince the parents that the treatment is available for this particular condition, and many of the congenital heart disease can actually be treated just by medications and may not require surgery at all. So it's very important not to create panic for the family. Now, with this in mind, how do we approach? First of all, when do we suspect that the child is suffering from congenital heart disease? What type of congenital heart disease it is? Whether it's a cyanotic or acyanotic, or are we dealing with a child who has an increased pulmonary blood flow situation or a reduced pulmonary blood flow? And when to intervene, and what are the options available, and what is the prognosis? Because once we answer these questions to ourselves, we can answer the questions of the family also. So when to suspect? In infants, if there is history of recurrent lower respiratory tract infections, if the child is failing to thrive or the infant is failing to thrive, not gaining adequate weight as per his age, falling off the curve, as feeding difficulty, which is interrupted feed, rest, suck cycle, or excessive sweating at the time of feeding. If the child is cyanosed or has spells, a murmur has been detected on routine physical examination, or there is a discrepancy in the pulse of the child. In older children, if there is dyspnea on exertion, chest pain or syncope, or cyanosis or squatting. One important thing here is missing is measurement of blood pressure. So any child above the age of 1 year, kindly measure the blood pressure, because that may detect a very important congenital heart disease. So how do the congenital heart disease actually present? So neonates, usually the presentation might be either asymptomatic with just a murmur, or maybe absolutely drastic, a collapsing child who is cyanosed, shock, or in congestive heart failure. Whereas infants and older children, they may be asymptomatic as a commonest presentation, the history of cyanosis with complaints of congestive heart failure or without CHF, and of course presence of CHF, which is the commonest way a child presents, a sick child presents. So acyanotic congenital disease, it's very important to classify, because once we are able to classify, then our examination will put them into one of the groups and we can pursue the management of these patients. So acyanotic ones are ones, there is a subgroup in this which has increased pulmonary blood flow These are the common left to right shunts that we deal with. These are atrial septal defect, ventricular septal defects, and patent ductus arteriosus. The other group is the one where the pulmonary blood flow is not increased. So these are the patients who will not present with failure. The first group presents with failure because the pulmonary blood flow is increased. The normal pulmonary blood flow includes the obstructive lesions like aortic stenosis and coarctation or pulmonary stenosis, and anomalous left coronary artery from the pulmonary artery. On the other hand, the cyanotic child may have increased pulmonary blood flow. So you may have cyanosis, child with cyanotic heart disease presenting in failure also. So these are the lesions: transposition of great arteries, total anomalous pulmonary venous connection, truncus arteriosus. And the commoner ones with cyanosis, which we all think, when a cyanotic child coming, we think it's tetralogy of Fallot. So it is those with reduced pulmonary blood flow. This is tetralogy of Fallot and the variants of tetralogy. So the first step in deciding what congenital heart disease child is faced with is cyanotic or acyanotic, or whether the second step is increased flow or decreased flow. So we go according to this. Cyanotic. So what is the cyanosis? Central cyanosis is the main thing that we are worried about. We are not worried about peripheral cyanosis. Central cyanosis means because skin and mucous membrane both are cyanosed. So that is the central cyanosis is cardiac in origin. And for congenital heart disease, any saturation less than 94% is put into a subgroup of cyanotic congenital heart disease. Our eyes can detect a saturation of only cyanosis when the SATs fall below 85%. For those where the SATs are above 85%, we may not be able to detect them, but they are also cyanotic congenital heart disease, and there the pulse oximeter has an important role to play in routine monitoring. So reduced or increased flow. Any child who has recurrent lower respiratory tract infection, who is failing to thrive or not growing well, has feeding difficulty, excessive sweating at the time of feeding, or has an hyperdynamic precordium or shunt murmurs or cardiomegaly. These are the children who have a pulmonary blood flow which is increased, which is resulting into these symptoms present in the children. On the other hand, the child where the pulmonary blood flow is less, like in tetralogy of Fallot, this child presents with cyanosis or with spells, and an older child may have dyspnea on exertion or squatting episode. He will walk some distance, squat for some time, and then again start walking. So this is a clinical thing. Now this has to be combined with a chest X-ray to actually know, because many times you may not be absolutely clear on a clinical finding. So increased pulmonary blood flow features of X-ray, this is what the X-ray might look like. You have child who is symptomatic child whose X-ray is So this is a symptomatic child, and there is a cardiomegaly and increased pulmonary blood flow. You can see the end vessels, which are multiple in number, and the vasculatures can be traced right to the end of the lung fields. That means the pulmonary blood flow here is increased, and the child is in the subgroup where this is the child who will present in congestive heart failure. On the other hand, we have an X-ray where the heart is small and the lung fields are actually black. The lungs are not receiving much of the blood. So this is a child who will present with cyanotic spells, as in tetralogy of Fallot. Once we have put on the basis of clinical examination and on the basis of chest X-ray, we can put into subgroups. So one next important step is to get a reliable echocardiogram. The most problematic thing is many a times we get an echocardiogram which does not explain the symptoms of the child. So it's very important that if the clinical signs do not fit the report, you should go with your clinical suspicion and not with the echo report, because you need to ask the echocardiographer to repeat an echo, because it may not be he may actually be missing something. So it's very important. The clinical suspicion is most important as far as congenital heart disease is concerned. So next important thing is, when do we decide to send a particular child for treatment, whether the child has to be operated or whether that child can be medically managed. This is an important question that you need to answer, and that the parents will come up to you repeatedly. And along with that, the thing is that once the surgery is done, is the child going to do well? What is the long-term future of the child? Because if the surgery is done and the child does not have a long-term future, that particular parent is going to come back and visit you again and again and tell you the same thing, that you send the child for surgery and my child is not doing well. So for acyanotic heart disease, secundum atrial septal defect, this is one of the commonest lesion, and usually the children are asymptomatic, and elective closure needs to be done at somewhere around 2 years of age or whenever they are diagnosed after that. Very rarely do we need to operate a child below 1 year of age when they present with intractable CHF. This is very rare. ASD with CHF is rare. The treatment options include device closures of the ASDs for secundum atrial septal defect as shown in the video, and surgical repairs which are for other varieties of ASDs like sinus venosus, primum, scimitar syndromes, coronary sinus ASDs, and some secundum ASDs which are not suitable for device closure. Most importantly, ASDs have excellent long-term prognosis, a single surgery and 100% long-term survival and good quality of life for future. No looking back after that. Ventricular septal defect, they are the commonest correctable congenital heart disease. They may present as an asymptomatic patient with murmur, or a child who is severely symptomatic, or an older child who presents with effort intolerance, and very frequently we see a child who has now become totally inoperable because he has not been operated on time. So VSD once picked up on echo is usually not an emergency, except if there is an additional lesion which has been picked up, especially arch anomalies, because if these are present, then the VSD needs to be addressed early. Otherwise, the VSD does not need to be addressed. What worries us in a VSD? The first thing that comes to our mind is, what is the size of the VSD? Kitna bada VSD? How much millimeter this VSD is? Is it really important? As far as a pediatric cardiologist is concerned, the size of the VSD does not hold any importance. It is the effect of the VSD on the heart, on the child, and on the pulmonary effect, pulmonary pressures, that is which is going to decide whether that VSD needs to be managed or not, and not the absolute number of the size of the VSD. So on the basis of these features, which is clinical examination, chest X-ray and echocardiogram, the VSD is differentiated into large, moderate and small. Large are the ones where there is cardiomegaly present, and along with that there is also pulmonary hypertension. Moderate are the ones there is only cardiomegaly, that is on echocardiography volume overload of LA and LV. These two subgroups, large and the moderate ones, are going to be symptomatic, whereas the small ones are not going to be symptomatic, because you can notice small VSDs do not have any volume overload or pulmonary arterial hypertension. So when to operate these children? Large VSD, usual time of surgery is between 3 to 6 months. Earlier may also be done if it is very difficult to medically manage congestive heart failure, or if the weight gain is not appropriate, or if pulmonary hypertension is developing. The weight is not a criteria to decide whether the child is operable or not. Even very small babies, as low as 2 kg babies, can be operated successfully for VSD closures. Moderate VSDs, the management is usually individualized, is medical managed till we can manage. If on medical management the child continues to gain weight, we don't need to intervene. But once on medical management, if there is no weight gain, or the child continues to be in CHF, or pulmonary arterial hypertension develops, this child requires early surgery. Small VSDs usually do not require to be closed, and the only reasons they need to be closed is if there is an aortic cusp prolapse resulting into aortic insufficiency or an episode of infective endocarditis. Now, apart from surgery, the other options for VSDs are that we can, the muscular VSD selected ones can be closed also by device closures, so where the surgery is not involved. Excellent long-term prognosis in today's era. Even surgical mortality for a VSD is less than 0.5% in today's era. So once a surgery is done, the child has a normal life ahead of him. PDAs. Now again, a very large PDA, baby not gaining weight, there is no point in waiting for closing an PDA. And moderate PDA, we usually wait till the child is about 5 kg of weight, and then the PDA is closed. Small PDAs, here the small PDAs cannot be left alone. Even small PDAs need to be closed because of the risk of infective endocarditis. So they are usually closed beyond 1 year of age. And in today's day and age, the PDAs are usually closed without surgery. They are closed in the cath lab by device closures. And rarely a preterm PDA is the one where the child needs surgical closure, and the management of preterm PDA is entirely different. So PDA, again, it is one-time closure, normal lifespan and quality of life. So again, it's a lesion which is closing it gives gratifying results. AV canal defect, most commonly seen or endocardial occlusion defect, is most commonly seen in children with Down syndromes. They require surgery very early because these children are symptomatic quite early in infancy. Preferably, you cannot wait beyond 3 months. It has to be done around that time, but not necessarily. It can be done earlier also. Prognosis is good long-term prognosis, but not as good as VSDs or PDAs or ASDs. Reoperation rate depends upon the degree of left ventricular AV valve, left AV valve regurg, that is a mitral valve regurg, the new mitral match, how much it requires. So these are the children who may require repeated surgeries because of the AV valve regurg. Now, obstructive lesion, the commonest one is coarctation of aorta, and it may present dramatically in newborn when this neonate will present with shock, with feeble femoral pulses, and then this child will need urgent intervention. And an older child, normal LV function usually is intervened around 6 months of age when they present with hypertension, and usually if the child is totally asymptomatic and no hypertension, an intervention may be required around 2 years of age. You don't need to hurry in a coarctation. So this is an echocardiographic imaging of coarctation. You can see this is a civilian narrowed aortic arch, arch just beyond the arch. This is the coarctation area, and this is the flow across the coarctation segment. The mode of treatment is surgical correction less than 3 months of age. Balloon dilatation is done if the child is more than 3 months of age, and stent deployment is considered once the child is beyond 10 years of age, because that is a permanent treatment once the stent is put in. So this is a schematic diagram where the images are not that good, but showing the balloon dilatation in case of coarctation, and this is a stent being deployed across the coarctation. The other obstructive lesion is aortic stenosis. They may need to be treated early if the child presents on shock in early neonatal period and needs urgent intervention, whereas infants and older children will need treatment if there is LV dysfunction, or in presence of normal LV function the child is symptomatic or ECG STT changes are present. An asymptomatic child will require treatment only if the echocardiography shows a gradient more than 75. If the gradient is less than 75, there is no need to treat this child. You can just follow this child up. Now, this is how we do it. This is the right ventricular pacing going up and the balloon being dilated across the aortic valve, and this usually relieves the aortic stenosis. Pulmonary stenosis is treatment if the child is symptomatic or if there is right ventricular dysfunction and gradient more than 60 millimeters of mercury, and here also it is treated by balloon dilatation and no surgery is involved, and these children also do very well after this procedure is done. Now, this is the biggest thing, cyanotic congenital heart disease, because it is life threatening at many times if it is not dealt with at appropriate period, especially in newborn. This is a subgroup where the neonates are going to present and the neonatal treatment is going to be required. So, those with increased blood flow, we again go with our TGAs, truncus, TAPVCs, and those with reduced flow are tetralogy and its variant. So, if a neonate present, the neonatal presentation, we need to decide when do we start prostaglandin E1 in these patients or not, because this may be life saving. Usually it is needed if we have a cyanotic neonate where there is a murmur, or minimally cyanotic neonate where there is differential pulses, or very sick neonate in shock with absent pulses, non-responsive to usual septic treatment and or ventilation. Most importantly, these are the indication for starting, but these are not the absolute indication, because the threshold of starting prostaglandin is directly proportional to severity of child's illness. Many of the time, you will have a neonate who is absolutely sick, very cyanosed. You may not have a murmur, but that does not mean that the child does not have a congenital heart disease. It might actually be a very serious duct-dependent lesion. So this was from Journal of American College of Cardiology in 1986 that they have established this indication. So for lesion wise, it's mainly needed for duct dependent pulmonary circulation, duct dependent systemic circulation, and for lesions where there is mixing like transposition of great arteries. So it is usually effective till around 2 weeks of age, beyond which the efficacy decreases. So first 2 weeks is the best time to give Prostin if the child suddenly presents a crashing neonate has presented to you. So do we need to do echocardiogram before Prostin? This is the commonest question asked. Yes, echo is not needed before starting prostaglandin, because by the time you get a reliable echo, it might be actually too late. So it has to be started on clinical suspicion, and more so if treatment is being contemplated, it is very important to start it, because if the child reaches in stable condition, the outcome is also very good. Cyanosis with increased flow is TGAs. So this is usually the X-ray in patients with TGA, agon side appearance, huge heart with increased flow. They may require initial stabilization in the form of prostaglandin E1. Once they reach to the tertiary unit, we may need to do a balloon septostomy, whereby the atrial septum mixing is improved and the saturation is improved. And this is just a palliative procedure. Because I have shown this because many times when this procedure is done and the child goes home, it is considered that the definitive treatment has been done and the child does not get treated further. The actual treatment is neonatal arterial switch operation, has an excellent long-term prognosis, normal quality of life. Surgical mortality in today's era is less than 2%, and the freedom from re-intervention is as high as 95%. So again, one-time surgery most of the time, and the child does not require another treatment, and good outcome. TJV, the VSD is usually closed around 3 months of age. A total anomalous pulmonary venous return is needs to be closed around 6 weeks of age and earlier if the child presents with obstruction of the TAPVR and again has an excellent long-term survival and only single surgery. Truncus arteriosus closed around 6 to 12 weeks of age. Again, neonates are extremely symptomatic in failure with this lesion. Cyanosis with reduced flow. The sine qua non in this is tetralogy of Fallot. And there can be other diagnoses, but the most common one is tetralogy. The surgical decision making, the ideal time for complete repair in these children is around 6 months to 12 months of age, and if the oxygen saturation approaches 75% or even a single episode of spell, the child needs to be surgically corrected. Types of surgery is actually based on age of the presentation and pulmonary artery size. If the child presents with severe cyanosis below 6 months of age, a BT shunt may be necessary, and after that, usually if beyond 6 months of age, we usually do a complete repair. This is how the complete repair is done. These are the surgical pictures. The VSD is closed, the right ventricular outflow tract is repaired, and the function of the RV and the tricuspid valve is repaired. You can see the patch here. This is how this is the right ventricular outflow tract patch where the VSD has been closed. Now, single ventricles, a word about them. They also present in two ways: high flow where they may need a neonatal PA banding, low flows where they need a neonatal BT shunt. Subsequently, at around 5 to 6 months of age, a Glenn surgery is done, and finally Fontan around 3 years of age. Now, where the left ventricle is a dominant ventricle and the right ventricle is small, these have good outcomes. Whereas the right ventricle is a dominant ventricle and the left ventricle is small, the outcomes are guarded in those lesions. So finally, the timing is of paramount importance, not only of surgery but also of picking it up, because if you have picked it up at appropriate age, the institution of just medical management will help your child grow really well, gain weight and everything, and outcomes of all varieties of left to right shunt, that is asymptotic with increased flow, are very good. Even TOF repair, arterial switch operation and total anomalous pulmonary venous connections have a good outcome in today's era, and with better preparation and selection, even single ventricles also have good long-term survival in today's era. Thank you.
Thank you, Manvinder. You have very nicely covered the topic, starting from when to suspect and going on to finally surgical management. Both the groups, acyanotic and cyanotic, and as he has very rightly said that now even at a very young age, it is possible to operate upon these children, and majority of them, and many of these, there is only one time surgery, and the outcome is very nice, excellent. Any questions? We have 2 minutes for discussion. If there are any questions, please. All right, just one thing from my side. Most of the time, or many times it is being asked that if there is a very small VSD, it will close on its own over the time period. Should we wait for that? How long do we wait? And if the child is symptomatic, operation should be done early.
For a child with small VSDs are usually asymptomatic. They're very rarely symptomatic. So small VSDs are the ones where the spontaneous closure is the highest. If there's small muscular VSDs, there are 80% chances they may close by 4 years of age. If perimembranous VSD, there are also good chances that they may also close. But most important is, if the VSD is really small, the child is asymptomatic, even if that VSD does not close, we don't need to close it unless and until we have an aortic valve prolapse developing, resulting into aortic insufficiency, or an infective endocarditis has developed. Otherwise, we do not need to close small ventricular septal defects.
Because the only problem is that you are exposing, probably maybe that the child may develop infective endocarditis. That is why
but if you see, as far as ventricular septal defects are concerned, there are very less.
The incidence is not that high.
Incidence is very less for infective. Even now, the American Heart Association has strongly recommended to stop giving infective endocarditis prophylaxis for VSDs. But we still continue to give, but because the incidence of infective endocarditis is very less in VSDs.
Thank you. Any other? Please. Just a minute, please.
You need to take the help of either a child psychologist
or
a psychiatrist. The most difficult part to initiate, to solve the problem is that it is very difficult to motivate an adolescent to go to a child psychologist or to a psychiatrist. such situation. That's the beginning of the story.
So it is known that it is his pediatrician with whom the child is very comfortable with. If the child has been seeing you regularly, he will listen to you. Maybe you will need one or more than one visits to convince him. This is where you need to talk to the child. You need to explain him that confidentiality factor will be looked after, and you will have to also make him understand that at this stage he needs help. Probably if you are able to convince him as his pediatrician, he will definitely give it a try. Not only the child, you have to actually talk to his parents as well. Take the child into confidentiality and tell him that this is what I am going to talk to your parents about. Maybe not divulge all of it, but at least alarm the parents about what is happening. So these two things must be done in the presence of the child so that he realizes that he is not being made a victim of the thing, and that actually his doctor is trying to help him a little.
Yes, Dr. Vijay, last question and then we close.
My question is addressed to the chair, to the Indian Academy of Pediatrics, through Dr. Piali, that rather than leaving a child on the parents to be brought to the pediatrician, I personally feel there should be an effort from the IAP forum to approach these people either through school health scheme or through any other organized forum, because this is a group which really has difficulty in communication with their parents. They are more connected to the peers, so there has to be constant effort. Is there anything going on from the IAP
I
forum?
agree with you, sir, but this is our chance when we go for the school health programs. That is where we are helping them out, and during that assessment, if we find any behavioral problems in these child or any other adolescent health problem, that is where we can help them through the schools. Nowadays, the schools have counselors. We can even talk to them about the child and talk to the child and his parents as well when there is a school's teacher meeting, parent-teacher meeting. So that way we will be help a more number of children. So all pediatricians who are going to these school health programs, the CBSE schools at least that I know of have an annual health checkup for the schools. And some of us must be going there. That is where we can ask them to help us.
Yeah, IAP has already a program which started I think 5-6 years back when Dr. Nair was the president, and life skill education programs was there. We had visited many of the schools. I have also been in some of these schools with this team, and they have really actively promoted that these kind of adolescent issues, health issues, should we talk to the children, maybe in a group and then later on maybe in the school. So you are absolutely right that IAP should from its own side start working actively on this part rather than wait that the children will come to them. So IAP is doing, and maybe in the next year when Dr. Bansal, who is very much interested in this field, you will have such more programs in the President's Action Plan.
So wherever adolescent chapter is very active,
Yeah,
for
they are already
example, in MP and Maharashtra,
everybody is under
they are
IAP
holding these
basically.
kind of workshops very regularly in schools and colleges, and it is being taken very seriously by the chapter. Thank you very much.
Thank you very much. Thanks organizer and both my speakers for covering the topic so beautifully and for your discussion.
Sir,
Thank you.
I would request you to hold a draw first. Dr. Sunil, can you help me in that? So you just have to take the 5 names out of it. Let us see who are lucky. Lucky draw.
Okay. So only those who are present here will get the
No, sir.
prize?
No. Anyone. They have to collect the prize from Alchem stall in the trade area. Dr. Khastagir Janakpuri.
Dr. L.K. Bharti, Patparganj.
Dr. Lalan Bharti.
L.K. Bharti.
L.K. Bharti is Dr. Lalan Bharti.
Dr. S.K. Jain,
Dr. S.K. Jain.
Dwarka.
Dwarka.
Dr. Sunil Bhatnagar.
Dr. Sunil Bhatnagar.
And Dr. K.D. Narang.
And Dr. K.D. Narang. You can
Congratulations to all the winners.
You can take your prize from the Alchem stall in the trade area. And sir, Dr. Dubai, I would request you to hand over the honor to Dr. Pyali and Dr. Maminder. thank you, Dr. Pyali, Dr. Manvinder, and Dr. Dubey for this great session.
Thank you.
Now let's move. Would like to welcome Dr. Harish Pemde, who is Professor of Pediatrics at Lady Hardinge Medical College, Kalavati Saran, on the dais. He is a very active member of adolescent chapter, one of the founders, and is currently secretary of the chapter. I would request Dr. Harish Pemde to introduce Dr. Nandini and Dr. Rajiv.